Hello, everyone. Greetings again. My name is Jay Shah, and currently I work as an intern. This is the second video in the series of MCQ discussion on second year MBBS examination, and currently we are focusing on pathology. The previous video discussed MCQs related to cellular adaptations, injury, cell death, and in this chapter we'll be studying about cellular inflammation, the various events involved in it, the mediators of inflammation, and finally processes involved in tissue healing and repair. So without further ado, let's start. Just an important disclaimer, these MCQs are from your previous year exams as only. These are not of NEET level, and uh, wherever necessary, I have provided the necessary explanation, but I have tried to be as brief as possible. I had received suggestions that the length is a bit long. Since I am also new to it, I would recommend that you would watch it at 1.5x or 1.7x due to paucity of time. So without further ado, let's start. The first MCQ is, following are the major effects of interleukin-1, TNF-alpha, except. The answers, the options are fever, fibroblast proliferation, neutrophilia, and chemotaxis. Now, interleukin-1 and TNF-alpha, both of them are basically pro-inflammatory cytokines. So they mediate fever. Do they mediate fever? Yes. Do they mediate neutrophil proliferation? Yes. Do they mediate neutrophilia? Yes. Do they mediate chemotaxis? No. Chemotaxis is generally mediated by complement factor C5a and leukotriene B4 and interleukin 8. So you need to remember this. Chemotaxis, C5a is most important, as you will see in subsequent MCQs. It has been repeated n number of times. So C5a, LTB4 and IL8, these are responsible for chemotaxis. For fever, fibroblast proliferation or neutrophil proliferation, you have interleukin-1 and TNF-alpha. The next is bilateral hilar lymphadenopathy with non-caseating granulomas. So now this question is focusing on granulomas. So what is a granuloma? A granuloma is a specialized collection of activated macrophages, which are known as epithelioid cells. Now, depending upon the necrosis which it has, it can be a caseating granuloma or a non-caseating granuloma. In the previous chapter, we did study that caseating granuloma is a type of caseous necrosis, that there is necrosis which resembles a cheese. In non-caseating granuloma, there is no necrosis per se, but there is formation of granuloma. That means there is accumulation of lymphocytes, activated macrophages, fibroblasts, and giant cells. So this question is asking bilateral hilar lymphadenopathy with non-caseating granuloma. This question is typical. It indicates sarcoidosis. So the answer is sarcoidosis, because in TB you will have both caseating and non-caseating granulomas. SLE, again, you'll have granulomas. It's a type 3. You won't generally have that. In leprosy also, you'll have granulomas with acid-fast bacilli. In leprosy and TB, you'll have acid-fast bacilli. And sarcoidosis, it's an autoimmune disorder with a non-caseating granuloma. So what are the questions? Okay, what are the respective types of granulomas? It can be asked as an SAQ, so it's just better to know the options. Otherwise, you can always write about it. So caseating is TB, histoplasma, and coccidioidomycosis. Non-caseating is sarcoidosis, Hodgkin's, Crohn's. Eosinophilic is Church-Strauss syndrome. Palisading. Palisading means a fence-like pattern, that is for vaginous granulomatosis. Dirk's granuloma, this question has been asked, that's why I've star marked it. Dirk's granuloma is due to Plasmodium falciparum, and stellate granuloma or star-shaped granuloma is due to cat scratch disease. If you are able to remember, donut granuloma or a donut shaped granuloma, that is for Q fever, right? So always remember caseating, because this will be asked in your vivas as well. Caseating is TB, histoplasma coccidioidomycosis. Non-caseating is basically sarcoid, Crohn's, Hodgkin's. Eosinophilic is Church-Strauss. Dirk's is Plasmodium falciparum, and stellate is cat scratch disease, right? So let's move to the next one. So this is the table which you know, it is just better to go through it once again. You can pause the video and you can go through it. Sarcoidosis is generally, it's the etiology is considered to be autoimmune. There's no specific infectious agent which has been found to be implicated in it. So you have TB, syphilis, leprosy. All of these are important SEQs as well. So it is always better to go through them. Cat scratch disease is rounded or stellate granuloma, right? And sarcoid is non-caseating granuloma with activated macrophages, right? Arachidonic acid metabolites include all except thromboxane, kallikrein, leukotriene, and lipoxin. So what is the answer? So the answer is because kallikrein is derived from the plasma, and whereas arachidonic acid metabolites, they are derived from the plasma membrane of the cell. So arachidonic acid is basically a 20 amino acid long acid. So there are two main enzymes, COX and LOX. So COX is cyclooxygenase, LOX is lipoxygenase. So the name, from the name itself, you can guess. Lipoxygenase, you'll have the formation of leukotrienes, lipoxins, and prostaglandins. Whereas for COX or cyclooxygenase, you'll have prostaglandin I2, which is known as prostacyclin, and thromboxane A2. So the answer is pretty clear. The answer is kallikrein because it's plasma derived. Thromboxane, leukotriene, lipoxin. So thromboxane is derived from COX, whereas LOX derivatives are leukotriene and lipoxin. Granuloma is an example of. So granuloma is an example of type 4 hypersensitivity reaction. Now, which are the various types of hypersensitivity reaction? It is always better to have a look at it. Type 1 is anaphylactic, which is basically mediated by your IgE or any allergies which you have. Second is type 2 is antibody mediated. You have antibody response against the offending agent. Type 3 is immune complex mediated. That is, immune complex is formed and that is being deposited. So that is type 3 hypersensitivity reaction. Type 4 is a delayed type of hypersensitivity reaction. That means the offending agent is not being removed by the body and therefore it is forming a granuloma. So type 4 is generally accompanied by a granuloma formation, and I have already mentioned the characteristic cells are activated macrophages, also known as epithelioid cells. The diagram of a granuloma is always asked in your SAQ, so it is always better to have a look at it. Again, there's a table from Robbins. One second. Yeah. So again, if time permits, pause the video, go through this table, and always remember the prototypical examples. Why? Because these examples will also be useful in microbiology. I'll just go through it. Type 1 is immediate, or which is basically IgE mediated, anaphylaxis, allergies. Systemic reaction is basically known as anaphylaxis, whereas a local reaction is known as atopy. Always remember that. Bronchial asthma, atopic forms, right? Antibody mediated is autoimmune hemolytic anemia, Goodpasture syndrome. Immune complex mediated is SLE, some forms of glomerulonephritis, serum sickness, and ulcers reaction. And type 4 is contact dermatitis, tuberculosis. Right. So multiple sclerosis, type 1 diabetes, tuberculosis, all of them are type 4. And these are basically mediated by our cytotoxic T cells, right? Most important factor in chemotaxis is, so the answer is C5A. As I already mentioned, C5A, IL-8, and LTB4. All of them are involved in chemotaxis. C3B is an opsonin. So C3B should be used for opsonin, whereas C5B to C9, that is a part of membrane attack complex, which is the final part of the complement cascade. So opsonins are C3B, FC fragment of the immunoglobulin G, fibrinogen, and mannose binding lectin. Always remember C3B and IgG, and along with fibrinogen. Four cardinal signs of inflammation were given by. Now, this is a very straightforward question. You cannot afford to point a wrong answer for it. So the answer is Celsius. So which are the four cardinal signs of inflammation? It is rubor, which is redness, pallor, which is heat, dolor, which is pain, and tumor, which is swelling. So all of these will lead to a loss of function of that affected site, right? So that loss of function is known as functional lesion, and that term was given by Virchow, right? So Rudolf Virchow coined the term the fifth sign, which is functional. All the four cardinal signs were given by Celsus. He was a Roman medic, and Elimechnikov was responsible for discovering the process of phagocytosis. So Elimechnikov is phagocytosis. Remember that. Characteristic cell of syphilitic inflammation. Now this is again a trick question. The characteristic cell is plasma cell. Syphilitic inflammation will also form a granuloma. You will have macrophages, epithelioid cells, but a characteristic cell is plasma cell. So the answer in this case is plasma cell. Don't forget it. Stable cells include all except. Now there are three main kinds of cells: Stable cells, labile cells, permanent cells. Permanent cells basically are neurons which won't divide. Skeletal muscle cells, cardiac muscle cells, they won't divide. Labile cells are those which have a high turnover rate, such as your bone, osteoblasts, those cells which line your mucosa, epithelial cells. Stable cells are all the organ cells which may divide in response to have a compensation, such as your hepatocytes. So when you have a partial hepatectomy, there will be compensatory hypoplasia. So they will divide, right? So stable cells include all except your hepatocytes are stable, fibroblasts are stable, endothelial cells stable, neurons. Why? Because neurons are permanent cells. So always remember these different stable, labile, and permanent cells. Ridley-Joplin classification, yeah, it's very important. Again, leprosy is an important topic. You cannot, afford to go through it. You cannot afford to not go through it. So it has basically 5 categories. You have mid-borderline, and above that you have tuberculosis, and below that you have lepromatous. So as you go downwards from tuberculosis to lepromatous, your prognosis decreases. So your first would be your first would be tuberculoid, then borderline tuberculoid, then would be mid-borderline, then lepromatous, and finally So from you first would be exclusive tuberculoid, last would be lepromatous. In between you would have borderline of both, and in middle you would have mid borderline. As you go downwards, the prognosis decreases because the severity of disease increases. So Ridley-Joplin classification includes all except there's tuberculoid, yes, there is borderline lepromatous, yes, there's mid borderline, yes, there's not indeterminate is not present. Yeah, so you should remember that. Right. And with respect to leprosy, 2 reactions are asked. Early reaction of Mitsuda and late reaction of Fernandez or something. So always go through it. Tuberculin test is an example of which hypersensitivity reaction. It is type 4 hypersensitivity reaction. Similarly, Lepromin test is also an example of type 4 hypersensitivity reaction because the body is not able to eliminate the organism. That's why there is an induration which is formed, which is seen after 48 hours, 48 to 72 hours, right? Typhoid fever is an example of. So typhoid, as you all know, it's an example of acute inflammation. So you should know the difference between acute and chronic inflammation. Acute inflammation is short duration. It is it is of a shorter duration. Main cells are neutrophils, whereas chronic inflammation is longer duration and the onset is also longer, right? Whereas acute is transient onset. And neutrophils, and here it is monocytes and lymphocytes, the cells which are involved. And systemic and local signs are more prominent in acute inflammation. They are less prominent in chronic inflammation because somehow the body has adapted or compensated to it. Which of the following complement factors acts as a chemokine? So which of them acts as a chemokine? Basically, it is C5A because it is responsible for chemotaxis. And what are chemokines? Chemokines are basically chemotactic cytokines. Never forget that. Chemokines are chemotactic cytokines, and the examples are your C5A, LTB4, and IL8. And which were your options? They were C3B, FC portion of IgG, and fibrinogen, and mannose binding lectin. Opsonins are, again, this question has been repeated. Opsonin is C3B. C5B to C9 is a membrane attack complex. And what is C3A? Always remember C3A is an anaphylatoxin, right? That is which is responsible in anaphylaxis. Laminin is seen in. Now, laminin, you might be tempted to mark it as lens or something, but laminin is seen in basement membrane. So, what is the composition of basement membrane? It has collagen type 4, proteoglycans, fibronectin, and your laminin. Never forget that. Laminin, fibronectin, proteoglycans, type 4, collagen. Right. Acute inflammation, pain is mediated by. Now, that is again a very important question. Pain is mediated by bradykinin, and bradykinin is derived from your kininogen cascade in the plasma. Right. So, bradykinin is acute inflammation. Important chemotactic agents are all except, as I mentioned, it's C5A, LTB4, bacterial end products. Now, why IL-1 and IL-1 and TNF alpha are? Those are responsible for fever, pain, those. Fever, basically fever and other signs of inflammation, not for chemotaxis. Now, bacterial end products is endogenous, and it is exogenous, basically. These both are endogenous end products. Bacterial is exogenous. And what is the product which they are referring to? It's N-formyl methionine. So N-formyl methionine in the bacterial cell wall, along with C5 from complement factor and LTB4, which is an arachidonic acid metabolite. All of them are important chemotactic agents. IL-1 and TNF-alpha are responsible for initial part and inflammation, pro-inflammatory markers. Granulation tissue is composed of all except capillaries, fibroblasts, inflammatory cells, granuloma. So again, it's a trick question. Granuloma has nothing to do with granulation tissue. Granulation tissue is exclusively your neovascularization plus fibrogenesis. Always remember this line. Granulation tissue is equal to fibrogenesis plus neovascularization. Fibrogenesis is your fibroblast proliferation and neovascularization is new blood vessel formation. And that is because of capillary expansion is because of VEGF, which is vascular endothelial growth factor, and fibrogenesis is because of your TGF beta, and inflammatory cell recruitment is because of your interferon gamma and TNF alpha. If you remember this, it's more than sufficient. Granuloma is a type 4 hypersensitivity reaction. Fibroblasts are seen in adipose, no. Myometrium, no. Granulation tissue, yes. Muscle fibers, no. Because here you will have adipocytes, myometrium, you will have smooth muscle cells, muscle fibers, you will have skeletal muscle or smooth muscle, right? And granulation tissue is, yeah, I can hear you, it's neovascularization and fibrogenesis, right? All of the following are tumors except adenoma, papilloma, gamma, leiomyoma. Again, a trick question. All of these, A, B, and D, these are benign tumors, whereas gamma is a tertiary form of syphilis. It's a lesion which is formed in tertiary syphilis. It's not having any neoplastic potential. So the answer is gamma. Syphilis is very important. There are three main stages in syphilis progression. First is primary stage, then you have a secondary stage, then you have a tertiary stage. Primary stage, you have a hard induration or a hard ulcer, which is known as a chancre. Hard painless ulcer on the genital region. When a person having a contact of sexual history or an unprotected sexual intercourse, your first reference should be syphilis. Treponema pallidum, right? That is chancre, which is hard. In secondary syphilis, you'll have generalized lymphadenopathy all over your body. In tertiary syphilis, you'll have specific lesions. You'll have gamma, you will have aorta, which is involved, proximal aorta, which is involved, or the ascending aorta, aortic syphilitis, syphilis, it is called. And then you have tabes dorsalis, right? Anaphylatoxin includes, again, it's C3A along with C5A. So the answer is both A and C. So now what, I'll just summarize what you have learned. C3A, C5A, anaphylatoxins. C5A exclusively chemotaxis along with LTB4 and IL8. C3B is an opsonin along with Fc fragment of IgG and fibrinogen and mannose binding lectin. So this much should be clear, or you just mark this in your notes or whatever you refer to for your studies, because it will create confusion at the end and I don't want you to lose your marks here. Common cold is an example of. Now, there are various types of inflammation depending upon the cellular reaction to it, right? So catarrhal inflammation is those which involves your mucosal membranes. Fibrinous inflammation is those which will include your, when there are coverings. So coverings that can include your pleura, your pericardium. So when there is pericardial involvement, we say fibrinous pericarditis, bread and butter example. Bread and butter appearance. So that's an example of fibrinous inflammation. Suppurative is anything which will have pus. So your common examples would be staphylococcal and streptococcal. Pseudomembranous inflammation in your tonsils. When you'll have diphtheria, there's formation of a pseudomembrane which is formed, right? So common cold is basically it involves your mucous membranes. There will be excessive running nose, that is known as catarrh. So catarrhal inflammation is an example, has an example in the form of common cold. Source of serotonin in inflammation is, again, it's very important. Serotonin is derived from your platelets. Never forget that. Serotonin is derived from platelets. Histamine is derived from mast cells as well as platelets, along with basophils. Because mast cells are basically larger versions or activated versions of basophils, but serotonin exclusively is derived from platelets. Catarrhal inflammation is seen in mucosal membranes. In pleura, you will generally see fibrinous or suppurative, any of them. Meninges also, you can see fibrinous or suppurative depending upon the organism. Bones generally, when we say acute osteomyelitis, Staph aureus, that is again an example of suppurative inflammation. Generalized lymphadenopathy seen in which form of syphilis? As I mentioned, it is secondary syphilis. In congenital syphilis, you will have a formation over your eyes, a membrane formation over eyes. Primary is chancre, secondary is generalized lymphadenopathy, tertiary is gamma, eotatic syphilitis, and Tavis dorsalis. Lepromin test is strongly positive in. Now, Lepromin test would be strongly positive in those conditions where there will be a tubercular component to it. So, tuberculoid form of leprosy, that will have a strongly positive Lepromin test. Because as the severity progresses, your test will be less effective, because this test is an indicator of your cytotoxic T cell response. So if your severity increases, your cells are not able to effectively neutralize them. So right, so tuberculous form has the best prognosis, so it will have a strongly positive Lepromin test, whereas lepromatous leprosy LL would have a bad prognosis, so the Lepromin test would be not strongly positive, or it would be weakly positive. Extrapulmonary primary TB complex can be located in. So whenever we say primary TB complex, it has to be basically lungs or your tissues which have some kind of lymphatics in it. So your lymph nodes, hilar lymph nodes, or your tonsils, those are tissues which have a lymphoid characteristic. So extrapulmonary primary TB is tonsils. Other than that, all organs is basically secondary due to dissemination or reinfection or reactivation. There's a very important chart which is given in Robbins, and I want you to go through that. So this one is talking about the pathogenesis of TB. Now what happens is, now C3b is, as I mentioned, it's an opsonin, mannose binding lectin. So this is mannose binding lectin and this is mannose binding lectin receptor. Both of them are basically opsonins which make the phagocytosis of tuberculous bacillus easier. So both of them are on the mycobacterium. You have the receptors here. So it is phagocytosed by your alveolar macrophages. But what happens is there is no elimination possible. Why? Because there is maturation arrest of the phagosome, which is formed. It cannot fuse with lysosome. So ineffective phagolysosome formation, maturation arrest of the phagosome, and lack of acidic pH. That will lead to unchecked bacillary proliferation, and it can seed. That is, this infection can go via lymphatics to multiple organs. How does the cell immunity work? Now your alveolar macrophage through your class 2 MHC. MHCs are coded by, this is again an MCQ, your major histocompatibility complex are coded by your genes on chromosome number 6. Don't forget that. So alveolar macrophages through MHC2 will present the Mycobacterium tuberculosis antigen to your naive T cells, and your naive T cells will get then activated to T helper 1 cells. They'll secrete interferon gamma, and in turn that will activate your alveolar macrophage. So what happens is your alveolar macrophage presents it to the naive T cell. Now your naive T cell will secrete interferon gamma. Interferon gamma is very important, and that will activate your macrophage again. So activated macrophage is known as an epithelioid cell. So the activated macrophage, now what can it do? Through free radical production, reactive oxygen species, and phagolysosome maturation and activation. Here it was arrested and ineffective. Now it has become matured and activated. So now this bacilli can be effectively neutralized. And again with that, it will release TNF and chemokines. Chemokines in the form of basically C5A, right? C5A is basically a chemotactic agent. So C5A is released, there will be more monocyte recruitment, and there will be a formation of a granuloma. So granuloma has central caseation, you'll have epithelioid cells, and you'll have a collar of lymphocytes, right? But in sarcoidosis, you'll not have a collar. So go through it, pause the video, go through it again, and if there's a question on tuberculosis, don't forget to draw this diagram. The second question is most effective bactericidal system in neutrophils. Now in neutrophils, there is a term which is known as respiratory burst. So respiratory burst is production of free radicals, and free radicals are in the form of H2O2 and HOCl. So H2O2 is broken down into hydroxyl radical by catalase enzyme basically. catalase or myeloperoxidase, both of them. So they'll form OH, hydroxyl free radical, which will combine with Cl or chlorine to form a halide free radical. And halide free radical is the most cytotoxic. So the answer is C, H2O2 myeloperoxidase halide system. All are examples of secondary TB. So secondary TB is basically that TB which has either disseminated from its primary position, or there has been a latent focus which is there, which has been reactivated, or there is reinfection with tuberculosis. So that is basically secondary TB. So Ghon's, the answer is Ghon's complex, because there are two terms. Never forget that: Ghon's focus and Ghon's complex. Now, Ghon's focus is basically an isolated tuberculosis focus. Generally, it is formed in subpleural location. Ghon's complex is when you have the focus along with lymphatics and the lymph node. So Ghon's complex equals to Ghon's focus plus lymphatics plus lymph node. Miliary TB is a form of disseminated tuberculosis. Miliary is because they appear like millets. TB osteomyelitis, again, it is disseminated, again, secondary TB. Cavitatory pulmonary TB, that has, because your primary focus has been modified to form a cavity. So again, that's an example of secondary TB. Primary TB does not present in the form of cavity. So the answer is Ghon's complex, because that is primary TB. A, B, and D are secondary TB. Again, it will become clear with the help of this chart from Robbins. I want you to look at it very properly. So you'll have a primary infection, you'll have a primary complex. What would be the primary complex be? It would be a Ghon's focus along with your lymphatics and perihilar lymph nodes. So this is your focus, Ghon's focus, lymphatics along with lymph nodes. So it will be the formation of a Ghon's complex. It can remain latent. Why? Because your immunity is good. It said that 70% of us have latent infections, especially Indians, because tuberculosis is very common. Now, either reactivation of that latent infection or reinfection can lead to secondary tuberculosis. Secondary tuberculosis, there will be changes at the primary site in the form of cavitation, scar formation, and the second point is it can progress to other organs, leading to progressive secondary TB. Your primary complex, which is formed here, if your immunity is good, it will form a latent lesion and it will generally then heal. But if your immunity is not good, the primary itself can progress. So it's known as progressive primary. It can spread to other organs, which is known as miliary TB, primary miliary TB. Or after reinfection or reactivation after many years after infection primarily, it can cause secondary TB, and secondarily it can get disseminated. So that is again in the form of miliary TB. Most common sites are basically your liver, spleen, your kidney, right? So primary infection forming primary complex, it can either heal, which is the best outcome. It can progress to miliary TB, or it can remain latent or dormant. Now that latent or dormant can get reactivated, or you can have a reinfection, which is known as secondary TB. You will have secondary changes such as caseation and scar formation. If that is not halted, it can progress to miliary TB again. Right? So I want you to remember this chart because it's very important. All are seen in tertiary syphilis except gamma hard chancre syphilitic aortitis stapes dorsalis. Hard chancre because that is an example of primary syphilis. The syphilis as an SAQ is also very important. Please go through that. Syphilitic gamma is seen in. So gamma is seen in tertiary stage, as I already mentioned. Which chemical mediator contributes most to rubor calor dolor? Now, in your unique or Bhalani, the answer is given prostaglandins, which is incorrect. The earliest mediator is histamine, because histamine causes vasodilation, so that will promote rubor and calor. And it also promotes post-venule dilatation, right? Post-capillary venular dilatation, which will lead to tumor. So all of them are generally mediated by histamine. Sinuses discharging sulfur granules are seen in. So it is the actinomycosis. Actinomycosis, you will have black discharging sulfur granules. So always remember actinomycosis and actinomycetes. What's the difference? It's given very well, and it's also expected in the form of an SAQ. The next question is most essential component of a granuloma. Again, the answer given in your Bhalani is incorrect. It is activated macrophages. It's not activated lymphocytes. Because I want you to look at this photo straight out of Robbins. Now in the center you have eosinophilic material, which is homogeneous, indicative of caseation. So it's caseating material. Then you have surrounding epithelioid cells, then a collar of these cells, mononuclear cells, which is your lymphocytes. So central caseation surrounded by these slipper-like cells, which are known as your epithelioid cells, which are activated macrophages. Then you have giant cells. Now, tuberculosis, the giant cells, they can either have a nuclear arrangement in the form of a horseshoe, or they can be at both ends. So it can be a bipolar arrangement, it can be a horseshoe arrangement. So these are giant cells. And finally, you have this mononuclear cells, which is a lymphocytic collar, followed by fibrosis or fibroblast proliferation, because you don't want your granuloma to grow. Compare that to this granuloma, there is a giant cell, there are epithelioid cells, there is a mononuclear infiltrate, which you can see pretty clearly, but there is no central caseous necrosis. So it can be sarcoidosis as well. This can very well be a sarcoid. Right, and here you have foamy macrophages. These all are foamy macrophages, and the eosinophilic material which you are seeing is your acid-fast bacilli. So again, it is tuberculosis. All are granulomatous inflammation except tuberculoid leprosy, yes, sarcoid, yes, giardiasis, no, it is an acute inflammation. Schistosomiasis, yes, schistosoma hematobium. Granuloma is a focal accumulation of activated macrophages, right? Keloid is an example of. Now, there are specific terms which you need to remember. One is keloid, second is a hypertrophic scar, third is desmoid, and fourth is contracture. Now, contracture is excessive wound contraction secondary to extensive burns. Then you have keloid, or I'll first say desmoid. So desmoid is excessive fibroblast proliferation, fibroconnective tissue, that is a desmoid. Then you have keloid and hypertrophic scar. So hypertrophic scar and keloid, one major point of difference is a hypertrophic scar does not extend beyond the boundaries of the initial insult or the initial injury, whereas a keloid has a tendency to extend. Second, a keloid has a neoplastic potential. Your hypertrophic scar does not have a hyperproliferative potential. Right. So deficient scar formation, no. Contracture, no. That is because of burns. Excessive repair, yes. Neoplasia, no. Keloid per se is not neoplastic. It does have a malignant potential though. Right. Gons focus is located in, again, it's an important question. There are two questions. Gons focus is located in upper part of lower lobe or lower part of upper lobe, whereas a cavity is generally seen in the upper lobe because the oxygen tension is high in the upper lobe. So Gons focus per se, that is a primary complex or a primary focus, upper part of lower lobe, lower part of upper lobe, and Gons, a secondary change to it, which is in the form of cavitation, that is generally formed in upper part of upper lobe, right? Leukocyte accumulation at periphery is known as, again, the answer given in your Bhalani is incorrect. It is known as margination. So there are generally 4 to 5 steps, if I remember. First is during your normal blood flow in your venules and your post-capillary venules per se, it's a laminar flow. Your leukocytes are moving along the center. Your RBCs are in the center, leukocytes are surrounding it. They move in a straight direction, which is laminar flow. Now, what happens is due to capillary expansion and due to post-capillary venular dilatation, your blood flow is sluggish. It becomes sluggish, so there is stasis of blood flow. What happens is your leukocytes are pushed towards the periphery. That is known as margination. Peripheral accumulation of leukocyte is margination. Now they'll start rolling along the endothelial cells. Rolling means there is attachment, there is detachment, there is attachment, there is detachment. So these are weak bonds. These are because of selectins. Finally, they accumulate at a particular site, and the attachment is pretty strong or severe. That is integral. So you will have integrins which mediate that. And finally, you will have diapedesis or transmigration. That is because of PCAM or CD31. Don't forget that. It's PCAM. PCAM is platelet cell adhesion molecule. So you have margination, rolling, adhesion, transpedesis, chemotaxis. Then they'll go that at that site, they'll get activated. So that is known as activation, phagocytosis, and finally you'll have removal of that organism by phagolysosome formation and elimination, followed by healing and repair. So this is the complete sequence you need to know. Most important molecule in diapedesis, as I already mentioned, it is PCAM, PCAM1, which is CD31. Rolling is facilitated by selectives. Adhesion is facilitated by integrins. And your transmigration or diapedesis is facilitated by CD31. Skin blister is an example of this type of inflammation. Now, whenever you have blister, again, there's an important concept here. The concept is between a transudate and an exudate. So transudate is basically serous fluid, hay-colored fluid, straw-colored fluid. That is transudate. If you have a burn, so at the form of burn, you'll have that serous exudate, serous transudate. Serous is always transudate, purulent is always exudate. So in serous, what you'll have, there's majoritarily fluid. So it is protein poor, cell poor, enzyme poor. Proteins, that means albumin is less. Cell is poor, that means your neutrophils is less because that is your cell of acute inflammation. And finally, your enzyme is less. That means your LDH is less. Now, since your protein is less, your specific gravity will also be less. So these are the 4 points which you need to remember to distinguish an transudate from an exudate. So transudate, low specific gravity, less than 1.020, low levels of LDH, low levels of protein, low levels of neutrophils. Whereas an exudate, that is purulent, it will have neutrophilic infiltration. It will have more amount of proteins. Your LDH levels will be high. Your CRP levels will be high. All inflammatory markers will be high basically. And finally, your specific gravity will be above 1.020. This is also known as Light's criteria when we use it for pleural effusion. So this question can be asked. Light's criteria is to differentiate between a transudative effusion or an exudative effusion in the context of a pleural effusion. Light's criteria, right? So see, skin blister is an example of serous inflammation, right? So this is the penultimate slide. What I want you to remember is the steps which are there in the healing process, the timeline. So at day 0, what will happen is your blood vessels will contract around at that site to limit your blood loss. Your cascade will go on, right? So that is a blood clot formation. Day 1, your neutrophilic infiltration is generally for 24 to 48 hours. So there's no surprise that on day 1, you'll have neutrophilic infiltration and basal level of your epithelium, which is there, which has gotten denuded, that will proliferate. So PMNL migration plus epithelial formation. Day 2, your epithelial formation continues. Day 3, what happens? Your macrophage arrive and your fibroblasts arrive. So after 48 hours, what will happen is you'll have the replacement of neutrophils by macrophages, and you'll have formation of new blood vessels. By day 5, you'll have abundant neovascularization plus granulation tissue plus collagen bridging. So basically, granulation tissue is both your neovascularization and collagen formation. Finally, on day 14, you'll have decrease in inflammation. That is, by 2 weeks, your inflammation subsides. By day 28, your scar will form. So if I want to, tell it to you in brief, day 0, blood clot. Day 1 and 2, basically your PMNL migration, cell proliferation, and thin skin formation. Day 5 is neovascularization, abundant granulation tissue. Day 14, that is end of second week, your inflammation will decrease. Day 28, you'll have scar formation. Also, there's a question which says, what is the maximum tensile strength which is achieved by the tissue? So it is at the end of 3 months, and it is 70% of your original strength, which can never be 100%, right? And finally, you have the questions which are important from both SCQ and LEQ point of view: your cellular events, vascular events, factors in wound healing, primary intention versus secondary intention, fracture repair process, keloid versus hypertrophic scar, actinomycosis, TB, leprosy, primary versus secondary intention. Yeah. So with this, I conclude the second chapter. I hope it was helpful. Again, thanks are due to many of my close friends, both within my batch and across batches. Again, I'm grateful to SJ and AJ as well for giving their inputs and helping me better organize. Thank you. Do keep studying. If there's anything I can help you with, do let me know. Best luck. Do well.